10 seconds. Okay, thank you. We are now live and we're ready to go. And thank you, Christopher, and thank you, the Right Honourable Hilary Benn MP. We are now live and we're ready to go. Sorry. Okay, today we are welcoming the Right Honourable Hilary Benn MP for our In Conversation panel discussion for our UCL IRDR 10th annual conference. Currently, we have around 100 participants joining us in this platform. And Christopher will be interviewing Hilary, and I'm going to quickly introduce Christopher. He has worked for the British Broadcasting Corporation, BBC, as a producer, reporter, foreign correspondent, and news anchor for over 23 years. He has extensive career on journalism, and it will take long to introduce him. But in brief, he previously worked as the spokesperson for the UN Peacekeeping Force in the Balkans and the chief spokesperson for the United Nations Relief and Works Agency for Palestine refugees in the Near East. He has extensive experience working for BBC, over 25 years. And Chris will be welcoming the Right Honourable Hilary Benn MP. I now hand over it to Chris.
Bays, thank you very much indeed, and thank you to the Institute for Risk and Disaster Reduction. Welcome all to this, the keynote session. I'm delighted, as Bays has said, to have with us the Right Honourable Hilary Benn, Labour MP for Leeds Central, who has served in Cabinet for 7 years and in the Shadow Cabinet for 6. Perhaps most important for this conversation, Mr. Benn was the UK's International Development Secretary from 2003 to 2007, and was key to the UK's and the international response during several defining moments of the global community's management of disasters, both man-made, such as the Darfur conflict in Sudan, and natural disasters such as the 2004 Asian tsunami. He was also Secretary of State for the Environment from 2007 to 2010, and in office during an outbreak of bovine tuberculosis. And with these experiences in mind, I'll also be asking him about the response, domestic and international, to the COVID pandemic. So, Mr. Benn, Hilary, if I may, welcome.
You may, of course.
Thank you very much indeed. Let's begin with the natural disasters part of this, the Asian tsunami. I want to start with a little bit of personal drama. It's the middle of the night, 26th of December 2004. You are DFID Secretary, and I assume you either hear the news on TV or radio, or someone calls you. Take us to back to that moment when you hear about the Asian tsunami.
Well, it was Boxing Day morning, and I came downstairs, and my son said, "Dad, you ought to look at this." And he had the television on, and it was reporting what was happening in Indonesia, in Thailand, in Sri Lanka, and it was immediately apparent that this was a major disaster because of the earthquake, which then generated the tidal wave. And very shortly thereafter, I was in touch with my office. They probably were in touch with me, and the DFID emergency response kicked into gear. The team that was leading it came into the office, and when a disaster like this strikes, the needs are really quite practical, because there are people who need shelter, they need food, they need water, they need medical care, and it is a huge operation to bring the international community plus domestic effort to bear on making that happen. In the case of Aceh, the coastal road had been disrupted at a number of places by the tidal wave. And
can I just say to people,
therefore the first question was, how many people are alive and where are they and how do you get to them?
Right, right. Can I just explain to people that we're talking here about the Indonesian province of Aceh that was very,
Yes.
very badly hit. But Hilary, can I ask you, you were obviously you were the DFID secretary, but you are also an internationalist. Did you not also look to the United Nations and its agencies, who you presumably knew had people in the region and perhaps even pre-positioned to deal with this?
Yes, it's all hands to the pump when a disaster of this sort occurs. It is a human tragedy on an enormous scale. It's also a humanitarian emergency. And the UN would get to work. So it's a combination of what UN agencies are doing, what national governments are doing, what relief agencies are doing. And it is practical. How do you get food and basic supplies to people who may have nothing because of the impact of the tsunami? How do you get it in there? So, for example, Aceh Airport, which I flew into on the 6th of January on an RAF C-17, we were bringing some equipment for the UN response because, of course, this is a regional airport, but the entire world was trying to fly in to bring supplies. And it so happened that the Americans had one of their big ships in the area, and their helicopters, I remember we landed and taxied, and there were these helicopters coming in and taking off, and they were taking supplies to the different communities along the coast, which had been cut off because the road had been destroyed. And then we drove into the town to I've never seen devastation like it in my life. The only thing I could relate it to were the pictures of Hiroshima and Nagasaki that you can see in the history books. And you realized as you looked around you, because you didn't quite understand what had been there before. And I remember looking at the ground, and suddenly I realized there were 4 sets of reinforcing rods flattened on the ground. And I realized there was a house here, and the water came in with such force that it literally stripped that house and all the neighboring houses off the reinforcing rods and slammed them flat on the ground. And I've never seen devastation like it in my life. But from dealing with this disaster and others, I came to some conclusions about the way in which the UN system works and the support which the international community gives
Hilary,
it.
Before we get there, can I just ask you to zoom out a bit from Aceh and to talk with your DFID hat on? On the one hand, you're having to coordinate the British effort, and as you said, on the 6th or the 7th of January, you said you went out to Aceh, but you must also surely have been looking to the UN. I mean, Britain is a leading member of the Security Council, one of the PERM5, the permanent members. What did you do in terms of coordinating with other countries? Because you must have known that your French, your German, your American, your whatever counterparts were also terribly involved, terribly seized, as they say, and presumably doing what you were doing.
Exactly. And our links are with the UN humanitarian coordinator, Jan Egeland, I think at the time.
Yes.
And we would give funding, because the first thing is who's going to fund what? So there were supplies which we would have arranged to deliver ourselves, supporting the delivery of supplies by relief agencies, the Red Cross, Save the Children, Oxfam, all of those, but also giving funding to the UN so it can get to work through its agencies. And so that is the first task. And then secondly, as the minister responsible, explaining to people in Britain, to the news media, what is Britain doing? Because people can see the pictures and they turn to the government saying, well, what are you doing to help? So you need good information about what is happening, where the needs are greatest, what practical steps are being taken, and people want to see the relief supplies arriving because that's what the folk on the ground need. But at the same time, a number of British people had been killed. So the Foreign and Commonwealth Office had a huge consular job of work to do, to go out and support families who had lost loved ones. People wanted to know where their families were. So it wasn't just a crisis affecting the Department for International Development, it affected the whole of the government. And I think for the next month, it was about all I did, because it was, I mean, it's such a disaster. Getting on for 300,000 people were killed by this earthquake and the consequent tsunami.
Now, Hilary, you said just now that you had certain reflections. Is it appropriate for me just to ask you a little bit about the UK response before we get on to the wider reflections? An FCO report of the October of 2005, so within a year, identified 3 broad areas for lessons learned. One, public information in terms of deaths, casualties, and victim identification. In other words, the consular issues you've just been referring to. Secondly, having appropriately skilled rapid response teams pre-positioned. And then thirdly, the coordination between the various agencies which we've been talking about. From a British point of view specifically, if the tsunami were to happen again tonight, do you think the world would be prepared?
That's a really good question, and particularly relevant in the light of COVID. I think realistically, to have teams pre-positioned in different parts of the world where a natural disaster might strike is not a realistic policy for other individual countries. In the case of Indonesia in particular, of course, a lot of the people who would otherwise have been responding from the local administration had either been killed or were trying to find out whether their families were alive. So one has to understand in that case, a lot of the capacity, because it is the local authorities, the local people, local government, which bears the biggest responsibility for responding to humanitarian urgencies and then asking others for help. That capacity had been really severely impacted by the sheer scale of the disaster. And I think I would say on coordination that we can always do better. I'll give you an example. In this and other disasters, we would take time to try and find out where can we get helicopter capacity from, and DFID would charter helicopters from other parts of the world. When you think about it, where is most helicopter capacity to be found? In armed forces of most countries. And I argued subsequently that there really ought to be, through the UN, a kind of call down agreement that in the event of a disaster of this sort, you will be able to call on a proportion of the military helicopter capacity, which you may need to find out where people are alive and to deliver supplies in the immediate aftermath. Because realistically, even DFID, a very well organized, highly professional, I can't praise the staff who worked for the department and worked on that crisis and the others too highly, unbelievably professional and dedicated. But we're not going to have helicopters in a box sitting around waiting for a disaster. Why not make use of the ones that we have, albeit in another capacity?
Now that segues rather nicely to what I was going to ask you about, which is the UN Central Emergency Relief Fund, which you were someone who backed very fully. Has it lived up to your expectations?
Well, it's certainly improved the situation. And it was a meeting actually in Khartoum that led me to come up with my officials with the idea of the Central Emergency Relief Fund, because I was meeting a number of the release agencies, and when it comes to providing food, the World Food Organization is clearly responsible. When it comes to health, the World Health Organization. But for other bits of the emergency response, clean water, tents, accommodation, it wasn't crystal clear. And I remember asking a question, and the people on the other side of the table said, I'm not sure who's dealing with that. And they kind of looked to each other, and the question rippled up and down the table. And when you think about it, in almost every disaster, the first thing the UN done is to issue an emergency appeal for funds to enable it to respond. Well, let's draw a completely different parallel. A fire breaks out today in UCL, heaven forbid, and someone picks up the phone and rings the fire brigade, and the fire brigade says, we'll be there as soon as we can. They put down the phone and they issue an appeal, urgent appeal from the London Fire Brigade for funding to put diesel in the fire engines. Can anyone contribute some ladders? And the truth is, since the UN has the lead responsibility in the world for responding to humanitarian disasters, it just struck me that it doesn't make sense that the first thing the UN does is to appeal for funds. It ought to have a body of money available to it to get on immediately with the initial response, and then it can appeal for more funds. And that was the idea behind the Central Emergency Response Fund. And I launched the idea to speech at the ODI. And within a year and a bit, I was in New York proposing it to the UN. It was agreed, and we set it up. And the UK made, of course, a very large, significant initial contribution to the fund. So it was an idea that came out of my direct experience as the minister responsible for leading the UK's humanitarian response.
And briefly, is it functioning? Is it working to your satisfaction?
Well, it certainly is working, and it's a lot better than the system that we had before, where the UN was having to appeal for money to get going, because that really didn't make any sense, did it? Well, I didn't think it did.
Now, you've led us to Khartoum. You said that light bulb moment, which led to the establishment of the Emergency Relief Fund, was there. Let's move on to Sudan, to Darfur, and an international response to a man-made disaster. In 2003, fighting breaks out between rebel groups and government forces. They're accused of ethnic cleansing of the region's non-Arab population. It's clearly a political crisis, but with grave humanitarian consequences. First of all, what was the political response?
Well, this was above all a terrible humanitarian disaster for the people who had been burnt out of their villages. What was going on in Darfur, the Janjaweed militia, who it was alleged were operating with the connivance and support of the Sudanese government, were raiding villages, burning them, and people were forced to flee from their homes. So the first requirement was to care for the people who had nowhere to live. And a whole series of refugee camps were set up. The United Kingdom was the second largest donor to support that humanitarian relief effort after the United States of America. And it's quite interesting when you think of other humanitarian disasters man-made as a result of politics. There were not that many marches in London calling on the Sudanese government to stop what they were doing. It was really quite striking how things happen in some countries and people get very exercised, but that was not the case in respect of Darfur. And I hope it was nothing to do with the fact that the two countries that were doing most to try and protect the people happened to be the United States of America and the United Kingdom, who were doing the right thing. The second thing I would say, it wasn't just a humanitarian crisis, it was a political and a diplomatic and indeed a military crisis. And I'll be frank and say that the government of Sudan was extremely difficult to deal with. They put obstacles in the way of humanitarian supplies coming into the country. I remember a particular discussion about vehicles that the UN needed. Eventually they were given permission to enter Sudan, but minus the radios. Now, there's not much point having a vehicle if you can't communicate with your staff, because the UN has a responsibility to protect its own workers. Now, eventually, the African Union decided to put a mission into Darfur to protect the camps. And I very strongly supported that. And we spent some aid money on buying vehicles and fuel contracts so that the AU soldiers were able to have vehicles and were able to patrol, because people were leaving the camps, women in the main, searching for firewood. Sometimes they'd be attacked. So the patrols were really important to give those in the camps and those venturing outside a sense of security. Now, we came to the peace negotiations in Abuja in 2006. Although these were peace talks, it was decided that I, as the International Development Secretary, would lead for the United Kingdom. And I went out there. And in the end, a deal was done with one of the rebel leaders, Mini Manawi, but the other two wouldn't play ball. And it was a very intense 3 or 4 day process in which you were negotiating line by line to try and get an agreement between the government of Sudan and the rebels at that time. And it taught me that in a crisis like that, where exactly is the dividing line between the diplomatic, the humanitarian, and the military. The fact is, in Darfur, all three of them were inextricably intertwined.
But is it also a lesson that could be drawn from that, that humanitarian aid in the absence of meaningful political processes is never going to be money well spent, to put it perfectly frankly? And you were a minister in a ministry that is pursued by the right-wing press on an hourly basis to show value for money.
Well, it's money that is very well spent on keeping people alive, giving them shelter and food and education, because don't forget, when families are displaced for a long period of time, children need to be going to school, because otherwise they are missing out. But you're absolutely right, Chris, that humanitarian aid alone does not solve the problem. And if the problem isn't fixed, then you continue to pay out a very large amount of money to deal with the symptoms of the crisis without fixing it. And that requires politics, it requires diplomacy, it requires political leadership. And you know, the easiest thing in a conflict, because conflicts end in one of two ways: either one side wins or both sides have to compromise. And it is sadly often easier to continue to say, I am the victim, you are the oppressor. And you go around the other side of the table and the person saying, no, 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 I'm the victim, you're the oppressor. Now, if you carry on like that, you could say, well, I stood up for what I thought was right, but you're not going to solve the problem, and you have to meet in the middle. And if you look at the long-running conflict in Northern Ireland and think how that extraordinary day, the Good Friday Agreement, was signed, came about, it was in the end courageous political leadership. Leaders who said to their own sides, look, folks, we can carry on with where we are, or we can realize that we're going to have to compromise in the interests of a living alongside our fellow human beings with whom we share a particular piece of territory. And it was an extraordinary vindication of what politics, diplomacy, effort and energy can do. And we still see the benefits of that in Northern Ireland. I can think of other places in the world where it could do with that, not least the Middle East.
Hilary, well, absolutely. I mean, that's a very good example, the Middle East, where a government, and particularly our government, but others, are prepared to spend huge amounts of money on mitigating the humanitarian impact of a political crisis. Look at Gaza, how much is spent reconstructing Gaza after 3 wars in the last 10 years, but so much less is spent on political capital into dealing with the underlying problems. But let's move on, because we have 2 big subjects to tackle before we go to questions. Bovine tuberculosis, 2007, you are Environment Secretary. There's an outbreak of bovine tuberculosis. First of all, just for people who don't necessarily have the background, what is this and how did you become aware of the problem in Britain?
Well, it is a disease that affects cattle. It is, of course, a form of bovine TB. When you discover that cattle have BTB, they are killed. We had a big outbreak in Britain in 2001, which actually resulted in the delaying of the general election in that year. People will remember the piles of carcasses being burnt when the army had to be called in. So an inquiry was done into that, and a number of recommendations were made about what you should do in future. Now, as it so happened, I'd spent about a month dealing with the flooding in 2007. I'd literally arrived in the job in the middle of the most terrible summer floods. And I'd just gone away on holiday. I'd been away for 23 hours with my long-suffering family when the phone rang and my private office said, I'm sorry to have to tell you, there's been an outbreak of foot and mouth disease, as it's called. And I knew at that moment I was coming back. And about 20 minutes later, Gordon Brown rang me from his holiday, slightly nearer to Whitehall than I was, and said, I'm on my way back, Hilary. And I said, well, I'll be following you. And what we did on that day was to put in place a movement ban, because the most important lesson from 2001 was, as soon as you know you've got a case, it's the equivalent of lockdown in COVID. You say nothing moves while we try and find out where is this disease? In 2001, before that happened, it had spread all over the country. Now, as it turned out in this particular case, it probably came, my eyes sort of rolled towards the ceiling when it became apparent. In all probability, it came from a government research laboratory, because the drains were in poor condition, and because of the flooding I referred to earlier. This had carried foot and mouth virus that they were working on to the surface, and it probably then spilled out onto the road. A lorry went by and took it to the first farm. And in the end, I think there are 8 or 9 farms that were affected. But you had to have the lockdown to find out where else is it. And of course, the farming industry was saying, well, how quickly can we get back to operation, because this is having a huge economic impact upon us. We thought we had it under control and we eased the restrictions. And then a couple of weeks later, I was told there's another case. Now, it turned out it wasn't another case. It was one of the original cases that hadn't been identified. But we had to go through another round of lockdown, and the farming industry understandably was less happy about that, because they thought we dealt with it earlier. And this involved working very closely with the chief veterinary officer, who was giving advice to me as the minister about what needed to be done. But in the end, the politicians have to take the decisions. And then as the politician, you have to explain to farmers and to the general public why we're doing what we're doing, and how the handling of the epidemic unfolds. And that was, I learned a lot from that, because you ultimately, as the Prime Minister says, the buck stops with you, because you're the one who takes the decisions.
I want to ask you about that in a second, about whether you as the Minister or whether Number 10 was in the driving seat, really. But before we get there, this question, which again I think has implications for COVID, which we're going to come on to, of present economic impact and the action you have to take now versus preserving the long-term survival of the sector. Clearly the two things are related, but how did you go about trying to get that balance right? And who did you listen to? Was it the scientists? Was it the economists? Was it the politicians?
And the farmers, you have to listen to everyone, but you've absolutely put your finger on it, Chris, because you are balancing those two things. Now, there was a debate about whether we should vaccinate cattle in a ring. And that was, again, one of the recommendations. You should consider it. We were ready to do it, but we thought at the time that we had it under control, having put exclusion zones around the places where the disease had been identified. Now, the issue about vaccination is the moment you vaccinate cattle, they cannot be exported, because you couldn't then tell the difference between an animal that had had tuberculosis naturally and an animal that appeared to have tuberculosis because it had been vaccinated against tuberculosis. And you need what's called a DIVA test, differentiating infected from vaccinated animals, in order to tell you the difference. So that was really an economic judgment, because farmers would much rather to be able to sell their cattle in the UK as well in the rest of the European Union. And the rest of the European Union, the last thing they wanted was any bovine TB heading their way. So you had to deal with the Commission and through them other agriculture ministers, because the EU put very tight restrictions on, because while we're trying to sort it out, they don't want it spreading to other places. So it has huge implications. And that is was very big for the farmers, but that's a small example of exactly the problem that the government is currently grappling with when it comes to COVID.
Which we will come on to in one second. But on that question of the buck stopping at Number 10, which is how you just put it, can you give me an example? Were there any examples of where you, as the Environment Minister, wanted something to happen, but Number 10 phoned up and said, bigger considerations, we're going to have to overrule you?
In all honesty, no, not in respect of that, because I'm pretty sure that COBRA met the emergency committee, and the Prime Minister was there to start with, chairing it, and we agreed on what our response was going to be. in those circumstances, when COBRA is meeting, the first thing you need is good information about what is happening. Where are the cases? What are we doing to discover whether there are any more? What preventative action are we taking? How are we informing people? How are we explaining it to the public? So, of course, there will be times when Number 10 is saying to any minister on any subject that is in the news, can't you do this quicker, faster, differently? And government departments have to deal with Number 10 and the Prime Minister in those circumstances. But the purpose of the COBRA system is to get everybody who has an interest and knowledge and expertise, including Chief Medical Officer in the case of COVID and the Chief Veterinary Officer in the case of bovine TB, in the same room together, so there is a single agreed government response, because that is what makes most sense and is most likely to be effective.
So let's, Hilary, finally move on to our last section and COVID. Clearly there's going to be a public inquiry. We don't want to prejudge that in any way. Let's call this a lessons learned exercise. From all you have said about handling bovine tuberculosis, from all you said about listening to the scientists, getting the balance right between the politicians, the farmers, all of that, COBRA, etc. What for you, if I were to ask you for 3 or 5 big takeaway lessons from your career hitherto on what's going on now in relation to COVID, what might those be?
Well, I think the first is to have a contingency plan in place. And that is why we were able to move swiftly in 2007 to deal with bovine TB, because we had a template that we were able to work to. I think in fairness with COVID, it's turned out to be a different kind of virus, and a lot of preparation had gone into human pandemic flu. And indeed, I sat on a cabinet subcommittee in the 2008-9 where we went through a lot of the preparations for this. But it's a virus that hasn't quite behaved in the same way, and it's a novel virus, and scientists have been learning about it as we go. So I think that's made it more challenging. Secondly, the most important lesson is to act swiftly. And I would say that I think the UK was slow to get to the point of lockdown when one looks at other countries. And there are those who've argued that the death toll thus far would have been less if we had locked down earlier. And the third, just because I happened to ask Matt Hancock about advice on the wearing of masks on the 23rd of January. It was the first question I asked him. And he said at the time, it is not recommended that people wear masks at the moment, but we'll keep it under review. I think it's been pretty clear for some time that the wearing of masks is both a protection for ourselves, but also protection for other people. And I very much support the decisions that have now been taken to require the wearing of masks on public transport and now in shops. And I'm afraid I don't really understand people who say you're infringing my human rights. Well, your human right to give COVID-19 to somebody else, I'm afraid, is outweighed by the human right of someone not to get it if the chance of it can be reduced by all of us wearing masks when we're out and about, either in shops or while we're on public transport. The last thing I would say is there's no doubt that the shutting down of the country through the lockdown did have an impact, huge impact, and you can see how the infections have reduced. But you can also see the huge impact that it had on the economy. Now, why the UK has ended up with one of the highest death rates of the world and amongst the worst economic outcomes is indeed something that the inquiry is going to have to look at. But any government in those circumstances is having to try and balance those two things, because if you stay in lockdown for long enough and cut off all links with other countries, you'd eliminate the virus. But when you came out, you discover you didn't have an economy left.
Okay, Hilary, we've got some great questions.
Okay, good.
I want to move on to, but just one last thing. You haven't mentioned the World Health Organization, and in a sense,
yes,
you know, the UN is always a whipping boy. I know I worked for it, and I was the whipping boy in many ways. How do you assess the WHO's response to this?
I think it's done a pretty good job, to be honest. There's debate about how quickly they declared it a pandemic. But what I very much regret was what Donald Trump had to say about the WHO, because whether there may or may not be criticisms about the exact nature of the response, as there will be about the UK response and in other countries, and indeed in the United States of America and other countries, the last thing you do in the middle of a crisis is to have a pop at the people who are playing an absolutely vital role, not just in trying to handle this pandemic, but you look at the role that the WHO has played in other disease outbreaks, Ebola, and the rest of them. It is absolutely vital that we have an effective international system. And during my time at DFID, suggestions and reforms and other points that I and many others made were all designed at trying to make the international system more effective. And I'm afraid we live in an age when there are certain forces in the world that are trying to undermine the international rules-based system, trying to undermine the institutions that we have created. We don't need to destroy them. We need to make sure that they work more effectively, because we are more interdependent as human beings than we've ever been at human history. And a pandemic like climate change exemplifies our interdependence, because you cannot wall yourself off from the consequences. It's coming your way, whether you like it or not.
Well, on that both salutary note and on that clarion call for international cooperation at this time of crisis, I think we should move to the questions and answer session. And by the way, thank you so much. We've kept perfectly to time, Hilary. We said we'd move on at 25 to. It's now 25 to. A great question from Brian Eden. Brian, thank you very much. He asks you, Hilary, do you think the UK's decision to merge the Department for International, to merge DFID with the FCO, the Foreign Office, will benefit those most in need in the world? The question.
No. Why? Is the answer. Well, I'll tell you why. Because DFID is widely respected around the world. I work with the most extraordinary, passionate, determined, able, committed civil servants. Why would you want to shut down, by moving it into another government department, one of the most successful development bodies and organizations in the world? It escapes me. Secondly, and it's a party point, but I'll make it, the Conservative Party has form on this. This is the third time that they have taken an independent development department and moved it back inside the Foreign Office. The third occasion on which they've done this. And the third reason I'll give it, look, I hope it isn't going to affect what DFID does. I hope it's not going to affect the humanitarian response, and the quality of the staff will ensure that they keep doing a fantastic job. But it's what the Prime Minister said when he announced it in the House of Commons, because anyone who can get up and describe DFID as a giant cash point in the sky, literally my jaw went, what? Because what is the thought process behind that statement? When we've just been talking about how the money contributed by British taxpayers has been spent on tents and blankets and food and water and vaccinations and all of the things that DFID has contributed to. If you think it's a giant cash point in the sky, it said to me that the Prime Minister is woefully ignorant of what DFID is and what it does. And later on, he also said we need to make sure that British businesses get a fair crack of the whip, something like that, when it comes to contracts. Well, one of the reasons that DFID was established and why we passed the original International Development Act was that in the 1990s, there was a famous dam project. Now, it was a project that was to build a dam in a place called Purgau. And some of Britain's development money was used to fund it because it benefited British companies.
In Malaysia, we're talking about.
Yes, indeed, yes, that is the case. Yeah. And either your development budget is for the relief of poverty, or it is for the benefit of British business. And the moment you start to think about decisions as to the expenditure of that money on the basis of what benefits British business, you've lost your focus on reducing poverty. And so that alarmed me too. Now, the Act remains on the statute book, and we've got to keep it there because it says that DFID spending, development spending, can only be used for the purpose of the relief of poverty. And the 0.7% commitment, which I fought for, and I pay tribute actually to the Conservative government under David Cameron for reaching it and for putting that into law. Because that is how you get irreversible change, when you persuade the other party that may not have agreed to it originally to say, yeah, this is part of what we stand up for. As long as those two things remain, then I will be less worried, but it's a backward step.
Okay, I'm going to move on to another question. I'm taking, there are several anonymous questions, but I'm going to stick for the moment with people who've some named questions. This is from Alex Thompson, a gentleman who clearly knows what he's talking about. And I'm going to read this out because it's quite technical. One of the primary legislative drivers for emergency preparedness, resilience and response in the United Kingdom is the Civil Contingencies Act of 2004 and the linked contingency planning regulations of 2005. Evidence from the COVID-19 pandemic and other recent emergencies demonstrate numerous areas in which the legislation has been ineffective. What are Mr. Benn's views on the need for legislative reform in this area? That's quite a technical question, one I feel we should have served you notice of, Hilary. But
it's a very fair point, and the proof of the point, Alex, that you are making is to be found in the emergency legislation that Parliament passed to give various powers to handle the pandemic. Now, I think a lot of people probably would have thought that you had all the powers that you needed in the Civil Contingencies Act to start with. And I hope that one of the lessons to be learnt in the inquiry, and when we set up inquiries, I am most interested, I had to set one up in the wake of the bovine TB, the foot and mouth outbreak, and also the floods. For me, the most important thing is that it is a lessons learning exercise so we can get things better next time. And I'm less interested, frankly, in a finger pointing exercise, because if you take the debate about the science, people have said we are following the science. Well, let's be honest here, particularly when it comes to COVID, there isn't just one science, because scientists will always tell you, this is what we think we know, this is what we don't yet know, this is what might happen, but we're not entirely sure. And that then puts the responsibility back on ministers to decide how to take all of that and decide what it is that they should do. So I would say to you, Alex, that if the inquiry says, in the light of this, we need to update the Civil Contingencies Act to make sure that we have the right powers, then that would be a sensible thing to do. But it's also important to ensure that they don't sit there and are not used for longer than is necessary, because some of them are quite draconian, but ensuring that people went home, stayed at home to reduce the incidence of the virus was essential to saving people's lives. And that is the primary responsibility of any government.
Hilary, we've got two questions relating to COVID. I'm going to roll them together because we're running short of time. The first one is from Lina Dominelli, who says, can you say why the government paid so little attention to the transmission of COVID in care homes? So care homes specifically in that question. And then one from Josh Anthony, I'll just read it verbatim. Thank you, Hilary. Many community-led mutual aid support groups have been emerging around London and the UK to help those shielding with general errands such as grocery shopping. Do you think this is a symptom, forgive me, of the government's lack of attention in this area? And what can they do to help communities with these tasks? So first one about, did the government pay enough attention to the transmission of COVID in care homes? And then what can government do to help these community-based initiatives?
Well, I do think that one of the lessons will be that what happened in care homes could and should have been better. I know Matt Hancock, who's worked incredibly hard. I mean, what a time to be doing this job. And I know, having done it myself in dealing with different types of emergencies, that it is not easy. Putting an arm around care homes, that was not my experience in Leeds, because there was the issue of people being moved into care homes who, it turned out, had COVID and hadn't been tested. And I think one of the other things that we didn't have capacity for to start with was to be able to test, because going back to the WHO, the Director General said at one time, test, 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 because if you're going to deal with the virus, you need to know where it is. That's the starting point. And then you can put measures in place to isolate people and to deal with the consequences. Secondly, care homes did not have enough personal protective equipment for the staff. I know that because I was on weekly calls, Leeds MPs, the council, and others. And people were saying, I can't get any supplies. The council was trying to give some supplies from a contingency stock that was held. We were very underprepared for the amount of PPE that was going to be required. And there's another lesson there, including dependence on international supply chains. Because of course, when everyone in the world was trying to buy PPE at the same time, they were looking to manufacturers in the same countries, and they couldn't fulfill all of the orders. So having the capacity domestically very speedily to ramp up production of things you know you're going to need, PPE for doctors, nurses and others, is I think another lesson from this. Josh, on your question, well, of course, for those who are shielding, the government has been providing food directly through the contract it has taken out with, I think, 2 food supply agencies, but it's undoubtedly been supplemented by the work of voluntary organisations. And I know a number of them, of course, in Leeds very well. Indeed, last Friday, I went to visit the Holbeck, which happens to be the oldest working men's club in the country, where a theatre organisation called Slung Low, well, it can't run any theatre events at the moment, has been organising the volunteer hub for Holbeck, delivering food parcels to people. And I've been following what they've been up to, and to see this room full of stuff, people, volunteers coming in and taking it out. And I think that that is a good thing, because it shows the capacity that we have in communities to come together. One of the volunteers who turned up said, we're working much better together now because of what has happened here. It builds links, it builds capacity, community, confidence. And the fact is, we benefit enormously in our society by the efforts of the voluntary and community sector. It's not a competition between the government, the state, and the voluntary and the community sector. It's a collaboration. Having said all that, the fact that last year 1 million people went up to a complete stranger in the 6th richest country in the world to say to them, I know we've never met, but can you give me some food because I cannot feed my family, is frankly a disgrace and something that should shame all of us. And we need to have a system in this country that ensures that people do not have to beg for food because they haven't got any money. And that is something we have yet to fix, and we must.
Indeed. A couple of other COVID questions, and before I ask them, apologies, I've just had a message saying I'm not speaking closely enough into my microphone, so forgive me for that. Karina Fernley, and let me again just read her question out verbatim. Thank you, Hilary. Great to hear your insights. My question is that the current government announced in early May that it will be creating a joint biosecurity centre, JBC, to bring together expertise and analysis to inform decisions on tackling COVID-19. To date, this centre does not exist, and there is no transparency over assigning the COVID alert level system, which seems defunct. What would you recommend as a way to generate more transparency and enable expertise to come together to generate new and innovative solutions and perspectives based on your experiences?
That is a really interesting question, because I can't think when was the last time I heard about the alert level. I remember when it first appeared on one of those press conferences, I think the 5 points on the scale. And at one point, a minister said, we're moving between one level and another. So I suppose the first question is, who is determining the level? Is it the Joint Biosecurity Centre? Is it the Chief Medical Officer and the Chief Scientific Advisor? Is it ministers? How is that decision taken? And I think the more that the level that is determined is informed by the tests that you're going to apply to decide whether it can be changed, the better. I'm in favour of maximum transparency. I think we should see the papers that go to SAGE, the Scientific Advisory group, because that enables us. In a way, I think it would help, because it would show that I'm sure the advice says this could be happening, that might be happening, this could be the outcome. You remember early on, there was a point where behavioral science was brought into this, and there was a fear expressed that if we lock down too early, people won't stay locked down long enough to have the effect. Well, actually, when we did lock down, the British people stuck to it pretty darn well. Now, maybe that particular behavioral perspective hadn't quite got it right. And the final thing I would say is that bringing together all of the elements must be to the benefit of tackling the disaster. And I take a completely separate example. Prior to the 2007 floods, the Met Office would issue warnings about rain and surface water flooding, and the Environment Agency would issue warnings about river flooding. And one of the recommendations that came out of the Pitt review, Michael Pitt did this excellent review on the floods. He said, it'd be a jolly good idea if you got the Met Office and the Environment Agency in the same room and they issue one consolidated warning, because for the public, if water's coming into your house, you're not much bothered whether it came from a river or from surface water flooding. And I went to visit the centre when it was created and literally saw the two people sitting 4 feet apart. And when we had the great flood in Cockermouth in 2009, I actually was in Brazil at the time, and the warning came through with a great big red marking over that bit of Cumbria, and it was, I'm afraid, all too accurate. And I turned up in Cockermouth in the middle of the night, and the high street had become a raging torrent, when the only way that anyone could get out was through the RAF helicopters that were pulling the remaining people from the tops of buildings. So, you know, forewarned is forearmed, and bringing people together is a really, really sensible thing to do.
Yes, indeed. Another COVID-related question, a rather large question, and then I think we'll move on for some final questions on some more general topics. This is from an anonymous attendee who asks, what will the post-COVID-19 UK look like this time next year, assuming that we are post-COVID-19 this time next year, and what will the government's challenges be? Huge question.
Oh, huge. I think that we don't know is the honest answer, but we do know this. Absent medicine, you leave on the steroid they've discovered that can help to reduce the severity of symptoms, but absent a medicine to treat COVID effectively and absent a vaccine, we are going to be living with this virus until a vaccine does appear. And then the question is, how quickly might one be discovered? How effective is it? How quickly can we produce the doses and vaccinate all the people around the world who need it? So even though the number of cases is significantly reduced, the virus is still there. And of course, everyone is worried about a second wave. And if you look back at previous pandemics, Spanish flu in 1918, 1920, well, it came in, I think, 3 main waves. That's the first thing. The second thing is, how can we do as much of what we would normally do while trying to continue to protect ourselves against the virus? And that is all about how workplaces operate and shops and so on and so forth. And the government is easing the restrictions bit by bit, which is a sensible thing to do. But it's down to our own personal behavior, because the only protection we have is what we choose to do. And if we're older, you can see the graph. You can see the graph for the death rate if you get it. If you're in, 0 to 20, it's very, very low, mercifully, unlike Spanish flu. By the time you get to 60, 70, 80, 90, well, you see what the figures show, and that should inform what we do and how we do it. I think the other question, because unemployment is going to rise, the economy has taken an enormous hit. This is not a time for austerity. This is a time for investment. This is a time for creating new jobs to replace jobs that may not exist anymore because of the impact of COVID. And I think this is the best moment of all to say, right, we've got another crisis that is around us and it's coming at us, and that is climate change. And this is the moment to say, right, we know that we need to get rid of all the gas boilers and gas cookers in every home in the country, to take one practical example. So how are we going to replace them? What are we going to replace them with? And won't we need a lot of people to make them and then install them in all of our homes? What, 18 million homes that have gas boilers and cookers? That's where the government should be turning its attention, because we need to get to net zero. And there's an opportunity here for a different kind of future, but it requires leadership from the top.
And Hilary, just before we
Yeah.
move on to something more general to end with, what do you think are the good things to have come out of COVID? I mean, when you look at, for example, how the workplace is functioning, people working from home more efficiently, people being more reflexive, people caring about each other more. What for you are the good things to have come out of this crisis?
Oh, look, it makes all of us realise, if we didn't already, what is the most important thing in life? It is the love and care and friendship of our family and those around us. And as the earlier question from Josh showed, you've seen that expressed by this extraordinary outpouring of community effort. There's a huge amount of community effort goes on in normal times, but you've really seen that come to the fore. I think the appreciation for care workers and NHS staff, but not just them, for council workers. For several weeks, we stood outside on a Monday morning to applaud the bin men as they came to collect the bins, because we depend on them. And I think it's taught our society a lesson about really, really important jobs that we haven't always valued in the way that we should have in the past. And I think it also teaches us that we can do things if we put our minds to it. Now, if anyone had said to you 6 months ago, we'll be able to build a hospital from scratch in a couple of weeks in the Excel Centre, most people would have said, no, by the time they've got the specification and the contract compliance and advertised it in the OJ and contracted and blah, blah, blah. No, we got on and did it. And the thing about a crisis is it clarifies what the problem is, it clarifies what needs to be done, and then the task for all of us, for communities, for civil servants, for voluntary organizations, local councils have done an extraordinary job. They are also part of the heroes of this challenge, and they need funding because they've got a huge hole in their finances. It shows that we are capable of making change, and being an optimist in life, when one looks at the big challenges, you can either be transfixed and immobilized by them and say, oh my God, we can't do anything, we're done for, I'm going back to bed to pull up the bed covers. Or you can say, no, look what we've done in the past, look what progress we've made, look what we've shown is possible. Now, let's take the same spirit and application and apply it to the tasks of today and tomorrow. That, for me, is the most important lesson.
Hilary, thank you very much. Just one very last thing. This is the last question, so let's do it. It's from an anonymous attendee. It's a global question in a sense. Do you think the world has learnt lessons to cope with another pandemic? Will we manage if another health crisis comes our way? So you've talked very much from a UK perspective, rather eloquently on this, but you know, with your international development hat on, with your expertise in setting up the disaster relief fund, with your knowledge of the disparate UN agencies, do you think that the world as a system with its own global system is better placed now, having lived through this crisis, to deal with one that might come our way?
Well, I jolly well hope so, for this reason. If you look at the risk register that I'm sure many countries have, here's the list of potential disasters that could befall us. Are we ready? The fact is, we weren't quite ready for this one for the reasons that I alluded to earlier. And next time someone says we ought to prepare for a pandemic, I think you're going to have more people in government and in politics and civil servants and administrations paying attention. We need to do the right thing, so we have what's required to help us respond, but we also need to recognize that each pandemic may come in a slightly different form, and that is when you need the world's scientists working together. There's been this extraordinary collaboration, which I think is inspirational, because that's what scientists do. They work collaboratively across borders, and loads of people are working on trying to find a vaccine and other treatments. I've had lots of conversations with scientists during the course of this pandemic, and I've learned a lot. We need that to continue. I can hear a happy dog barking. We're probably saying we've unfortunately run out of time. But since that was the last question, Chris, can I just say to to UCL, echo what you said at the beginning, to thank the Institute for the work that you do, because the subjects that we've been discussing in this last hour are really important. They have a huge impact on people's lives, and we must continue to strive to learn and to understand, and the Institute does a fantastic job in doing that. Keep up the great work, and thank you.
Sorry, I think I'm now unmuted. Do forgive Teddy, my dog. Hilary,
Hi, Teddy.
You very much. Thank you very much for being such an engaged and indeed engaging guest. It's a real honour and a privilege. I know how incredibly busy you are. So thank you very, very much indeed for sparing us your time. I speak for all of us really who've benefited so much from your experience and wisdom. So thank you very much indeed. And with that, I'll hand back to Bays. Thank you very much.
Thank you, Christopher, for moderating the session, and we all from the UCL IRDR and on behalf of all the participants, right now we have 156 participants here, want to thank wholeheartedly to both of you for participating in this much needed in conversation session, and especially thank goes to the Right Honorable Hilary Benn MP. You're very busy. We can understand tackling the pandemic and all other responsibilities. It's twice we changed the date of our conference and we moved from in-person to online. And thank you, truly, we are humbly thankful to you for agreeing from the very beginning. You said always yes. We have changed the platform. We have changed, the conference style, and you have been always with us. Thank you for your support, and also thank you, Christopher, for moderating. It was really lively, and we all enjoyed truly. Thank you both. Okay. Thank you, Hilary. So now we will move to our panel discussion 2 on COVID-19 pandemic and the health of refugees, migrants, and minorities. I will hand it over to Professor Kumar. Before I invite the panel members, we have in total 5 panelists, and it will be moderated by Professor Kumar. Before I start, I really want to thank Miriam Arkut from UCL Institute for Global Health and Lancet Migration. And she really organized all this, this panel, but unfortunately she could not participate at the last moment due to some personal circumstances. I now welcome Professor Nirmal Kumar, who is a medical graduate from St. John's Medical College, India. She has been working extensively with Lancet, different medical organizations, public health organizations, and universities. And she has vast experience working in similar field. So Professor Kumar, can you hear me? I give you permission.
Okay.
Yes.
Good evening.
So
good afternoon.
Now the platform is under your control. You have almost 90 minutes, and you can introduce, please, yourself and all the panelists, and we are now live.
Thank you very much, Bays Ahmed. And I'd first like to start off by saying thank you very much to UCL, to the Institute for Risk and Disaster Reduction for having this panel at their 10th annual conference. I'd also like to start off by saying thank you to Miriam Orkut, who managed to put together this excellent panel this evening. And if I can introduce the panelists one by one, and I'm sure their faces will come up on the screen. It's Aurélie Pontu. Aurélie, you're here. Hello. And and we have Professor Julian Alfredo Fernandez Nino. We have with us Professor Raj Popal. We have with us Guppy Bola and Dr. David Mosca. So welcome to, a very warm welcome to the panelists. And for some of the panelists, it's early in the morning. And as for me, it's late in the evening. I'm in Kathmandu, Nepal at the moment. And it's really a great privilege to be moderating this panel this evening. So I'd like to start off by saying that the objective of this particular webinar is to discuss how the novel coronavirus pandemic is disproportionately affecting the health of migrants, refugees, and minorities globally, and also to look at the response when it comes to these groups. Our speakers this evening in the first part will try to outline some of the main challenges, the risks, and how these populations have been catered for or left out during the pandemic, using both regional and global and country perspectives. So it will be a real pleasure to listen to what has been happening on the ground when it comes to challenges, risks, and response. In the second half, the panel speakers will then be asked to comment and give some recommendations about the way forward and how some of these challenges and risks can be dealt with. So without much ado, this is not going to be a lot of speeches from me, but we'll get started. And I'd like to ask our first panelist the question. So what we're going to do is we're going to go around with the first question, and each of the panelists have 5 minutes. And then after that, we'll come back to part 2. So the first question that is going to be discussed is the COVID-19 response in your region globally, and the inclusion and lack of inclusion of migrants and refugees and ethnic minority groups, including reviewing some of the challenges and risks for these populations. So I'd like to start off with Aurélie Pontu. She is a humanitarian specialist and coordinator, the forced migration team of Médecins Sans Frontières. And as we know, Médecins Sans Frontières is very much at the front line. So Aurélie, we look forward to hearing from you.
Please unmute.
She seems to be frozen.
Aurélie, are we frozen, Raj? I think
she seems to be frozen. Yes.
Okay. While we try to get in contact with Aurélie, maybe what we'll do is, if Julian, do we have? Is it okay for you? Are you able to speak? We can start with our second speaker, Professor Julian Alfredo Fernandez Nino, from the Department of Public Health at Universidad del Norte in Colombia. Julian?
Yes, I am here. Yes, I can do it. Okay, thank you for having me. Well, I'm going to talk about the Colombian experience as a migrant receiver. First of all, I would like to provide some background information in 2 minutes or less. Colombia is now one of the main migrant receiver countries in the world. Currently, almost 2 million of Venezuelans live in Colombia. In addition, this two-nation border, Colombia and Venezuela, is currently one of the largest bilateral migration corridors, with the third largest average annual increase in the number of international migrants. So the situation at this border is very complex and different. Colombia and Venezuela share a long border of roughly 2,000 kilometers, as well as similar background. But individuals and families move constantly in a pendular way, and number those who cross the border to migrate or to seek asylum. Besides, we have Wayuu people, among other indigenous groups, constantly move throughout what is for them a transnational territory. Therefore, our case, I mean the case of Colombia, is totally different from other migrant receiver countries. We are talking about here about a south-south migration. Despite Colombia being a middle-income country with no previous experience polarization, and access to health insurance for Venezuelan migrants. However, the persistent challenge is huge. More than 1 million of irregular migrants do not have access to it, and a high proportion of regular migrants have not gotten health insurance, even if they have the right to get it. Also, low-income migrants face the same barrier to access to health service that low-income Colombians do. Despite the fact that I consider Colombian health system to have had a positive response to the arrival of Venezuelan migrants, when faced with the challenge of COVID-19 pandemic, Colombia decided to close the border with Venezuela on March 16. This decision had and will continue having deep socioeconomic consequences for migrants and people living alongside the border, although humanitarian corridor has been installed. Additionally, in the last month, there has been an unexpected phenomenon of a Venezuelan migrants float returning to Venezuela, whose number is not exactly known. These migrants are returning, forced by the economic difficulties derived from the obligatory social isolation and the subsequent loss of their employment. Venezuela's capacity to receive and protect them is also unknown. And in the last weeks, Venezuela government has limited the access of their own citizens to their own country. The return of Venezuela certainly is something we have to care about. However, most migrants still live in Colombia and they will stay here during the pandemic. Also, some Venezuelans will come back to Colombia during the pandemic. But we have to think about the migrants inside Colombia because they are the majority. To finish, since the last months, the Colombian government has been working in the inclusion of migrant population in the framework of the response against COVID-19 through an action plan that includes responsible and humanitarian political management of the border, including the creation of humanitarian corridors for populations such as students, indigenous people, pregnant women, and people with chronic diseases. Second, guarantee of access to healthcare service, but according to the migratory status. Third, adoption of the international cooperation actions to respond to the current pandemic in migration populations, including catch money transfer, hygiene, caregivers and care facilities adapted for isolation, food delivery and hostels adaptation for homeless and workers. Fourth, psychosocial attention for most vulnerable populations, such as children, teenagers, and finally, resources focalization in highly impacted municipalities. Finally, this action plan follows some of the recommendations suggested by the World Health Organization, the United Nations High Commission of Refugees, and the International Organization for Migration. If I have time later, I would like to discuss how this implementation has not been easy. I think that is all to start. Thank you.
Please unmute. You have to unmute.
Thank you very much, Julian, for that very brief and concise overview of the situation. We are here now that Aurélie is back, and we're very glad that you're back, Aurélie. So it's over to you now.
Thank you very much, Gunness. I'm sorry I was disconnected. I hope it will be better now. So thank you very much for having me in this panel. So I work for Médecins Sans Frontières, Doctors Without Borders, and obviously COVID-19 has presented many challenges for the delivery of humanitarian assistance, and that's been an unprecedented situation. But as MSF, we are particularly worried for our migrant and refugee patients that are quite vulnerable to the epidemic. We have 3 different categories of people that we consider vulnerable in this outbreak. First, people living in camps, in informal settlements, in places where density of population, lack of access to water and sanitation, to healthcare makes it particularly difficult for them to cope with the situation and to protect themselves and implement the basic precautions that they need to implement to prevent the spread of the disease in such settings. We also have, obviously, amongst our patients that are migrants and refugees, also people at risk if they contract COVID-19. So people who are already suffering from pre-existing medical conditions, elderly people, but if they contract the disease in such settings are even more vulnerable. And obviously, as MSF, we are also integrating as part of our response specific programs for health workers and healthcare workers and frontline workers or essential workers. And we know very well that in many parts of the world, many migrants and refugees are among these essential workers, and they need to have all the precautions and the protective equipment and the training to be able to perform their duties in a safe and dignified way. As MSF, we have been first trying to adapt the provision of our services to COVID-19. We had to organize a specific triage at the gate of our clinics, of our hospitals. We had quite a diverse response in many countries for migrants and refugees. We, for example, had worked at projects in Greece, in Italy, but also Belgium, France, Bangladesh, Lebanon, Mexico. So many different types of contexts where we have assisted people in very diverse settings. So also open specific centers for patients suffering from some symptoms of COVID-19. We had set up hotlines for migrant workers in Lebanon, for people living in informal settlements in Rome, in order for them to maintain access to primary health care and to be able to be referred to proper health facilities if they had symptoms. And one of the main challenges that we have faced in this outbreak is obviously the lack of inclusion and integration of migrants and refugees in the public health response. So not only they have not been properly integrated, but we have seen very dangerous discriminatory practices in the delivery of public health responses to this type of population. So we have been faced with forced quarantine in certain contexts, the resort to collective quarantine in very bad conditions against the recommendations of the WHO. We have seen also increased resort to policing, to militarization in the implementations of public health responses in certain refugee camps, for example, in Bangladesh. We have seen people being forced to leave their homes, to go to quarantine centers, and this has created quite some distrust in the health response, which can be very dangerous if we are faced with the more waves of the outbreak. There is clearly more and more distrust from refugees in the public health measures. We have seen lockdown being imposed in a discriminatory and disproportionate manners. For example, as the confinement is happening in many countries, certain refugee population and asylum seekers are still under lockdowns. It's the case, for example, in the hotspots on the Greek islands, despite the population not being more exposed to COVID-19 than the general population. So we've seen that as a very big challenge that has impacted the response. And yes, we can discuss maybe some of the recommendations in the second part, but clearly states must do better if they want to tackle this outbreak and to make sure that all populations are protected from the outbreak.
Thank you so much. Thank you so much, Aurélie, for providing us with that overview. And I think you're really setting the stage for the challenges and the risks that you've outlined with all the different countries that MSF has been working in and seeing the situation on ground. So moving on quickly to our next speaker, Professor Raj Bhopal, who's Professor of Public Health Emeritus at the University of Edinburgh. And Raj is going to tell us a bit about the situation in the UK. Raj, over to you.
Thank you, Bernadette. There's two questions. What's going on and what's your recommendations? Do I deal with both or just one?
Just one.
Just the one. So what's going on? What's going on in the UK? Well, I think on the basis of our previous knowledge about ethnicity and health and disease patterns and the circumstances in which the ethnic minority populations of the UK live, and with what we know about COVID-19 and what it's like compared with other virus infections, including influenza, we would expect to find substantial variations in the incidence of COVID-19 by ethnic group and variations in terms of outcomes. And we're very lucky in the UK. We're quite advanced in this field. I've been working on it for the last 30, 40 years. And we have to give credit. The English health and statistical agencies have been able to produce statistics at a very high level, very high quality compared with most other countries in the world, with the possible exception of the United States. And indeed, exactly what we expected has been found. The other United Kingdom devolved countries like Scotland, Wales, and Northern Ireland, they've been much slower, but we can expect that this situation will be the same. Indeed, early results from these other places are indicating that the general principle that the findings will be much the same in the United Kingdom once all the statistics are available is correct. One thing I want to emphasize is that we must be looking at data by sex and by age group. And in the absence of data by age group, because the numbers tend to be small, we should be looking at age standardized rates. We should not be primarily examining complex models where lots of covariables have been put into the model, because those complex models are trying to explain what might be the cause of these variations, not actually measuring the amount of these variations. So whether we're looking at incidence, complications, or hard outcomes like mortality, there are big variations. People who we might call Black in the UK, we tend to call them Black or African origin, people with long-term ancestry in Africa, they have 3 to 4 higher rates of incidence and mortality compared with the white British population. South Asians have got about 2 to 3-fold variations, differences, and there's big differences between the different South Asian groups. Indians fare better than Bangladeshis and Pakistanis, which is not unusual. And the British Chinese population seem to be intermediate between the South Asians and the white British population. For many other populations, the numbers are quite small, so the data are less clear-cut. But by and large, the general principle that ethnic minority populations in the UK are faring worse from COVID-19 is almost certainly going to apply across the board. Now, we're not very good in the UK at producing statistics by immigration status, so it's harder to say what's going on. But when we examine data by country of birth, we tend to find in the UK the results echo those found by ethnic group. So we've had a massive controversy in this country around this issue. Some of the most emotional debates I've ever heard, even more emotional than Brexit and the Iraq War. Parliament spent 3 hours debating this openly. This is the UK Parliament, and it was an amazing debate, so open. And in this debate, we started to touch upon immigration policies, the no recourse to public funds policy, and the general policy to create a hostile environment for undocumented migrants in the UK, a deliberate UK policy which has been going on for quite a number of years despite severe criticism. Now, it's not a surprise that as we've begun to control the pandemic here in the UK, and we've been one of the worst countries in the world, by the way, we're far worse than the United States. To my knowledge, the only country in the whole world that's worse than us in the UK is Belgium, which doesn't get any attention at all because people don't look at the rates per million, they just look at the number of cases. They're worse than us, but otherwise we're just about top of the league for COVID-19. Scotland's done a bit better than England. We're much on a par with the United States. So what do we need to do? Well, that's the second part of the discussion, and I do have a few recommendations. Should I save them? Thank you. Okay, Bernadette, you'll need to, yeah, that's it.
Yeah. You can hear me now. Thank you so much, Raj, for providing a quick, rapid overview of the situation in the UK. And now we move on to Guppy Bola. And Guppy is a social justice organizer, trainer, educator, and writer, and chair of the Joint Council for the Welfare of Immigrants. And her perspectives, even though she is based in the UK, will be different from Raj. She's not going to describe the situation in the UK, but talk about specific areas. So Guppy, the floor is yours.
Thank you. Thanks for having me. And it was great to get a sort of background from Raj before I go into some detail on the immigration system. So I'm going to speak to a project that I worked on in April with a group called Migration Exchange, which was a collaboration, quite a speedy project that was undertaken within 3 or 4 weeks with a group of academics, policymakers, and myself to sort of help support it. That was to advise the migration sector in understanding the various risks that each person at each stage of the immigration system within the UK faces in terms of their risk of contracting COVID and the impacts that might have on them. So I just want to talk about the project and then look at the multiple ways those risks are playing out based on how someone identifies in the migration sector, and then what the UK government response has been so far. And I can just give you an update that that is actually very little, so that won't take very long. So yeah, the project connected data analysts, policy wonks, such as myself, and 2 epidemiologists to produce a framework for migrant rights campaigners. And for this, we looked at various demographic data such as age, gender, disability, ethnicity, and racialized identity. We identified 16 different cohorts within the immigration system and used the kind of framework to look at what the risks might be based on the percentage of individuals within each cohort based on data that we had access to. So there were many limitations in it because it was what we could use on what was available, but it was the best that we could come up with. What we found out was the risks of contracting coronavirus and being made seriously ill by it was obviously based on the lived experience of a person's language and their health literacy, the connection between households, environments and accommodation, the number of people within those households, and the agency that each one of those people had within the household. So that in itself is very gendered, as well as has an impact based on your immigration status and how much freedom you have within that household, plus your occupation, if you're able to work, and how you travel to work. And then the structural issues around that that could lead to worsening clinical outcomes as a result of contracting COVID-19 or other conditions that you might have, obviously include any underlying conditions and your capacity to deal with them. In the UK, we have a real problem with eligibility of care. We are told constantly that we have a universal healthcare system, but there are significant barriers within the UK to accessing healthcare, particularly in England, where, as Raj mentioned, the hostile environment plays a big role in deterring people to access care. There's a real issue with access to support from survivors of domestic violence, and currently the Domestic Violence Bill or Act that has been going through Parliament actively ignores the needs and rights of migrant women, and particularly trans women. So that is a concern and something that has not been attended to. And I think also an underlying structural issue that isn't addressed is the trauma and social exclusion that is experienced by people within the immigration system, and how that trauma is not just an issue of mental health, but how it's held in the body and the impact that that has on people's susceptibility to the conditions that they hold and the conditions that they acquire through both the pandemic and in everyday life. And then the third part of this is the sort of socioeconomic impact. So those within the migration system are actively prevented from accessing financial support. Raj again mentioned no recourse to public funds, so they're not able to access social welfare and housing supports. They've got no legal routes to work, forcing them either to do unsafe or illegal forms of work or illegalized forms of work, or to be very financially precarious. often in debt, also brought on by the large amounts of funding that is required to even go through the immigration system, and any dependents that people might have, whether it's children or remittances that are sent to families abroad. And what we found was that those most impacted are definitely those who are seeking asylum. So many of them hold these things called Aspen cards, which enable you to access about £39 worth of goods. And at the beginning of the pandemic, accessing anything was incredibly difficult. We noted that in detention center, there are still 368 people as of April the 23rd in detention, and detention centers are identified as incredibly high-risk places because of the lack of access to sanitation, the shared facilities, and difficulty of social distancing within them. And the third was those on tier 2 visas, a large number of whom are nurses, and a large number of whom have been subject, or have large proportion have died from COVID-19, and you see that through, there's a Twitter feed called Nursing Notes that has been documenting those who died from COVID-19 in the nursing sector. 39% of those who applied to this visa of tier 2 were actually healthcare workers, so it was a really high proportion. Do I have 1 minute to go through the government response to this, or shall I wait until the next question? Oh, Bernadette's disappeared. I'm going to keep going then. So just really quickly, the government have conceded to a couple of things, but in a very poor fashion. So they experienced a legal action by detention action in which they released 1,000 detainees. That was the largest number that had been released at the start of the pandemic from that dangerous situation. There's recently been some action on reducing the immigration health surcharge, which is an additional surcharge for any migrant who comes to the UK, who works in the UK, who pays taxes in the UK, and yet still has to pay to use the healthcare system. And they've removed that for healthcare workers. Although they noted this in April, but action to actually remove the healthcare surcharge has only just taken place in the last, I think, day or so. And there's some support for bereaved families and a scheme to support bereaved families. But these are really minor concessions in the context of the multiple barriers that migrants face in the UK. And there really needs to be much more that needs to be done around access to care, removing charges, fundamentally stripping back the hostile environment, putting a firewall between the Home Office and all public services so that migrants feel they're able to safely access public services, and preventing, doing more to actively encourage people to be included in the healthcare system, because we need everyone to be able to access healthcare, and there's evidence to show that it is discriminatory and preventing people to be able to receive the care that they rightfully can access.
Thank you so much, Yuki, and I think you were already giving us some of your recommendations, but we look forward to discussing them more in detail in part 2. And finally, our final panelist for the day is a veteran, and we all know Dr. Davide Mosca. He was the former director for migration and health at IOM, and he's now associate professor at UCL. So Davide, you're going to give us a bit of a global overview, but you're also going to talk about some insights with regards to Africa. So the floor is yours, Davide.
Thank you. Can you hear me? Okay. So good afternoon, good morning, good evening to everybody, and thank you for inviting me. I will touch upon 2 issues. The first one, the positive one, let's say, talking about the general migration and health policy environment that we have observed during this crisis. And I must say that I've been very impressed by the wealth of knowledge, understanding, statement, convergence of views, commitment that has come from civil society organizations coming together in statements by UN agencies, notably WHO, IOM, UNHCR, the High Commission for Human Rights, ILO, coming together. Academia, you mentioned, we are here in the UCL and also the Lancet migration platform, medical association, everybody. So I would say that the knowledge about this state has been unprecedented for those of us that have been working in this domain for years, is really heartwarming to see that, the things that we have been trying to preach forever have eventually come to an high understanding, and the hope is that, if the view is solid, that maybe we will come out better from this pandemic, that probably, hopefully, the community, the public opinion has come to the realization that you cannot have health security, public global health for all without including migrants. Incidentally, though, that there has been in this period that WHO has appointed the first ever full-time dedicated director of health and migration in headquarters, and we want to express to Dr. Santino Severo, who is at the helm of the migration and health in WHO, all the wishes for success. So, but amongst the many expression of high commitment, I want to mention also the UN Secretary General policy brief issued in June called the COVID and the People of the Move, that's basically summarizing many of the things the colleagues have said here. Identify in relation to migration, the COVID, 3 interlinked crises here. An health crisis, because migrants are definitely exposed to additional risk, but there is also a socio-economical crisis, because we know that the jeopardy put on them exactly because they are out of that social schemes and protection mechanism. And last, the protection crisis itself, because at the same time, the closure of borders, the delayed in process, the stop put to resettlement programs have created also a protection gap for many, particularly refugees and asylum seekers. So this again is a positive note. This understanding comes from the UN Secretary General. So it looks like really the community has come to the understanding of what the problems are in relation to migration and health. The Secretary General also identified in existing frameworks the ground on which we can come together in the realization of action. And he mentioned the social development goals, the UN migration network, the global compact for refugees and migrants are the domain in which these need to come together. And I want also to mention a publication coming from IOM and Asylum, the migration policy practice issue of June, that is fully dedicated to COVID. So these are governance, migration governance specialists that talk. These are not the usual health specialists converted to the cause. These come from migration governance specialists that recommend migration governance indicators in which to frame also the response to the COVID for migrants. So all in all, this is a positive note, something on which we need to work. The second part is the negative part, and is the fact that unfortunately some states have used public health concerns to justify more restrictive immigration enforcement or rules. So really the irony here is that migrants that are already vulnerable in conditions of migration, particularly in situation of health crisis, become even more made vulnerable by the same measures taken to control the epidemic. So here we are in a double jeopardy. And certainly the case Bernadette was mentioning, so what I have observed in Africa, the fact that the closure of borders, the control of borders, the restriction of movement, the restriction of asylum processes, the curfew, the detention, and eventually the deportation of migrants in irregular situation, whether in the Middle East or in North Africa, has not only put in jeopardy the health of people and the community where they have been brought back, but also caused additional humanitarian needs in countries that are already struggling with the response to the COVID and the response to many other catastrophes. So in the case of Ethiopia, we have seen at least 30,000 migrants being returned from the Middle East in many locations. Now imagine the quarantining them and providing them with care in situation of like the one we live, what strain can put on the countries and the humanitarian sector. In Niger, we have seen some 10,000 at least migrants being returned from Algeria in the middle of nowhere, again with the same situation. So the travel restriction, the border closure doesn't apply in this situation, and deportation keep going on. And I mentioned 2 cases, but there are many others. Now, of course, we cannot avoid to mention the fact that beside the public health and the health concern for these people, there is also the loss of income generated by this forced return, because these people were working where they were sending back home much needed income that sustained the family left behind. So this loss of income is definitely a big challenge for families in this situation. And the concern is also that these changes, this attitude might not change easily with time. On the contrary, we can expect that maybe measures of control and restriction taken now will be used in the future. We have seen also in the Mediterranean, MSF was mentioning, the question of closing harbors with the excuse of protecting migrants from being infected, so leaving them maybe at sea instead of rescue them and bring to safety. So, well, this is the situation. There are so much awareness on one side, but there is still a long way to go in order to ensure that that the rights of people are not put in jeopardy by this global health crisis. Thank you.
Thank you so much, Davide. You've given us a global perspective, and I think that after listening to all the panelists, we know that the picture that is emerging is quite grim. And COVID-19 is a rather grim picture globally in general, and the situation of migrants, refugees, and ethnic minorities is quite evident that this puts them also in a very precarious position. So now moving on from the description of the situation, both globally in countries and in regions, to asking our panelists what would be their top 2 recommendations in terms of how we can be more migrant inclusive and how ethnic minorities and marginalized groups can be at the center of both policy and research when it comes to COVID-19. So if we can start with Aurélie. And Aurélie, what would be your top 2 recommendations? Over to you.
Thank you. Yeah, no, I really enjoyed what Dr. Davide Mosca said, and I think my recommendations are very in line with this description of the situation. I think there are first short-term recommendations that we can make. There are great concerns over not only the response to COVID-19, but also the impact of lockdowns and restrictive measures that are justified by public health arguments on the access to healthcare of refugees and migrants. And I think there is much needed effort to mitigate some of the effects, notably in terms of access to basic health services, prevention of indirect death during this time of the pandemic. And there are many strategies that we can study and promote that have shown to work. For example, I was mentioning hotlines, medical hotlines This is a strategy that that I think can be promoted as an example of a way to make sure that people that are staying home, that cannot access health services in the way they were used to do so before, can still get access to medical counseling, to information. And these hotlines, they need to be adapted to the needs of refugees and migrants. They need to have translation. They need to have promotion of the existence of these hotlines. They need to have proper information on how they can still seek healthcare and find proper access to services. That's one very simple example. We need to mitigate as well the impact of the economic impact of lockdowns and the economic impact that also impacts access to healthcare. We see some of our patients unable to work and unable to buy medication. And in many cases, they have been left behind in the social assistance that was provided to the general population. And we have many people knocking at our clinics, unable to buy the chronic medications that they need. And there are also very simple strategies that can be put in place to make sure people that are suffering from chronic diseases can have sufficient stock of medication, can have specific access to pharmacies, or can receive financial assistance when they really need to access this medication. And this is something that we see missing in many countries. Of course, COVID-19 has also exposed the consequences of the lack of integration of refugees and migrants in health systems. And we need to really make an extra effort to study why this is the case. Most of the responses that MSF had to put in place, we have to put in place this more resources to do triage at the gate of refugee camps, to put mobile clinics in place, because refugees and migrants cannot access the normal health system. They are not integrated in the health response of the government. And this should not be the case. They should get access to health services like anyone else in the country. So we need to think in the long term what it means to have societies that are inclusive of all populations, and especially for the health of all. And then more long-term recommendations. Obviously, states need to rethink migration management and migration control. We have challenges today in these settings, in refugee camps, for populations that are in transit, that are in hiding because of migration control. Deportations, detention were mentioned. We know that these type of settings are a disaster for public health, and COVID-19 is only one more example of that fact. So clearly, we need to rethink the way we treat migrants and refugees in our societies, and now with a public health argument that can maybe push forward some of new ways of thinking about migration management. Hotspots that like we have in Greece should not exist. These conditions are unacceptable. They are also, exposing people to violence, to many health risks, and not only COVID-19. And most of the response that we had to put in place is because these places are disaster for public health, and they should not exist. There's a big concern that after COVID-19, we will inherit refugee camps, migration camps that are actually worse than before the outbreak, because a lot of services have disappeared. Many organizations have had to reduce assistance. There's been more restrictions. There's been lockdown. There's been militarization. And we see deterioration of the conditions in many of these settings. So there will be extra effort needed to go back to humanitarian standards in many of these camps, in Bangladesh, in Greece, but also in countries of transit where a lot of migrants and refugees have lost the assistance network that they used to rely on before COVID-19. So indeed, there are great concerns, but there's a lot of space to improve and to learn from that experience and from that outbreak.
So much, really. for that. And I see that some of the recommendations that we are coming out are going to be issues related to access to information, access to healthcare, access to medication. And so let's hear what Julian has to say from his particular perspective in Latin America. Julian, over to you.
Okay.
We can't hear you, Julian.
Okay, thank you. The implementation of the strategies needed to include migrants in the response against COVID-19 in Colombia as another Latin American countries continues to represent a great logistical and financial challenge for a middle-income country as Colombia, especially since it is not known whether the flow of migrants will increase during the progress of the pandemic. Colombia, for example, has called for increased international aid, and the consequence of the Venezuelan health system shortcomings on health and migration from that country are unpredictable. Finally, measures that affect whole communities should be taken after discussion and coordination between national governments, policymakers in all sectors, and public health academic. Both barriers to healthcare and discriminatory treatment could be presented, and this fact will lead to an environment where people diagnosed with the virus, infected or sick, may not receive the required treatment, generating a very high level of virus spread. In addition, Venezuelan migrants are also vulnerable because of not only the virus, but also the social effects of the non-pharmacological measures like the lockdowns. National governments must act in coordination, and migrants should be included in all decisions that impact their health and well-being. A deeper binational dialogue and effective cooperation between Colombia and Venezuela are therefore imperative. Also, I hope that the COVID-19 pandemic will not become an excuse for the implementation of the stricter migration policies, and that no additional burden will be placed on already vulnerable population in Colombia. On the contrary, this should be the opportunity to develop strategies to ensure that the migration population, regardless of its age, gender, or legal status, receive equitable healthcare in a framework of truly universal coverage. Due to the vulnerable conditions of migration, and given the health and social emergency that constitutes the pandemic for COVID-19, it's urgent that the national governments deepens and continue the inclusion of migrants in these strategies of intervention. In the context of the Global Declaration of Lancet Migration, of which I am a member, the following recommendations are made to the national departmental, local government, international cooperation agencies, and health authorities. I want to mention just three. First, urgent access to healthcare for all migrants and refugees throughout the COVID-19 response. Second, inclusion of all migrant and refugee population in the prevention, preparedness, and response to inequalities. Third, responsible, transparent, and inclusive public health information strategies for migrants. Finally, there is something that I would like to remark. We shouldn't stop protecting and improving the health of migrants during the pandemic. We cannot wait for the pandemic to end. It's not just the virus. We must continue promoting universal healthcare coverage for all migrants during the pandemic in Colombia as well as worldwide. Thank you.
Very much, Julian. And thank you for those recommendations that we will come back to. And now from Julian, moving to Raj. Raj, the floor is yours.
You hear me now? Can people hear me?
Yes, we can hear you.
I'm going to start off with a little bit of good news because there's not much. And then I'm going to come to my two recommendations. The good news is that for people under 20, This disease is certainly no worse than influenza. Maybe it's less bad than influenza. So for our next generation, my grandchildren, they're going to be all right. We need to look after them. Let's not let them get too hurt by what's going on with the older people. Now, this disease doubles its incidence and mortality every 7 years. Migrants and ethnic minority groups, on average, are quite a bit younger. A lot of migrants are in their 20s, and they're not going to be very badly affected by this disease itself. They're going to be affected by the lockdown measures, etc. So we need to remember that good news. Spanish flu was not like that, and SARS-1 was not like this. It affected the young people far more. So let's try and remember some of the good news. If not, it's not much good news. I'm going to turn to two recommendations, one of which I've actually sent some information on the chat, and that is, I've been calling for about 3 or 4 months now in writing and in various forums and through European Public Health Association and other organizations through the Lancet's migration platform for temporary citizenship for everyone within the boundary of every country in the world. There's probably tens, if not hundreds of millions of people who are in countries which are not, where they don't have nationality or they don't have citizenship. Without the citizenship, they don't get the public funds, they don't get the rights. I think people who see this as a 2020 phenomenon have got it quite wrong. This is going to be with us for 5 or 10 years. The social and economic impacts are going to be far, far worse than they are currently. We need this because we need everyone in the world involved to try and resolve the problem. If we don't, people will have to breach the guidelines. They will have no option but to breach the guidelines to survive. So we don't want people breaching the guidelines. We want people to follow the governmental guidelines on workplaces and homes and masks and everything else. That's my number one recommendation. My number two recommendation is that we have to tackle, obviously, systemic, institutional, and individual level racism. And that particularly means getting the messages and communications and services right. People have been saying to me, can you give an example of institutional racism? Because really, people don't understand what it is. Well, many learned articles have been written, quite a few by myself, on this topic, but really, people don't understand it. When I was given a platform on national radio and national television, I gave an example. I said the government's daily press briefings, whether it's the Westminster Parliament in London or the Scottish Parliament, they're institutionally racist. They're in high-level English. They use scientific and biological concepts that even I, as a professor of public health, find difficulty with, like R. And they're not there to meet the needs of the entire diverse population. There's nothing in any other language apart from English. We do have sign language for the deaf. We have 9 protected characteristics under the Equality Act 2010. What about the other 8 equality groups? Disabled is one, so we're meeting some of their needs through the sign language, which is for the deaf, but not to have the messages given in other languages. I've said, well, people have said to me, how can we do that? We've got 100 languages in the UK. So we've probably got about 8 or 9 major languages in the UK that nearly all the other people speak and are comfortable with, and you can have 1 minute devoted to each language every day, with the messages given in that particular language flashed up, what the key messages are. To me, that is a basic example of institutional racism. It's so deeply ingrained in the British psyche that everything's done in English that no one can even see that that is in any way a problem. And never mind racism, never mind institutional racism, never mind structural racism. But to me, it's the perfect example, and it makes people sit up and think. Now, we need to do something about this because I've already mentioned in the UK, the pandemic is now back in Leicester, and currently it's in Blackburn. It's been in Bradford. It's in Glasgow in a big way. And there's been 100 outbreaks per week in the UK. So we're exiting lockdown, and there's going to be 100 outbreaks every week for the foreseeable future for the maybe 5 years. And we've got to get those outbreaks under control, because they're all going to occur, or most of them are going to occur in populations where people don't have high command of English and understand the science, etc. So that's my two messages. Well, three messages I've given. One is, let's look at some of the good news, i.e. in the people under 20. Then the temporary citizenship, and thirdly, getting our communications right. And that means eliminating every form of racism, whether it's mild or severe. And in particular, I always feel it's the institutional racism that we must tackle more than anything else, because everything else follows from that. Thank you.
Thank you so much, Raj. I would just like to point out all the participants that the chat is very active. There are lots of questions coming up, and I would also like to request the panelists to just look at the chat, because some of the questions are directed to you, and I'll come back to that when we start the Q&A. I also like, there are 6 questions already on the Q&A, so please keep your questions coming as we move on to comments from the remaining 2 panelists. So Gupi, very quickly, your recommendations. You talked about some of this earlier, but if you could just name your top 2 recommendations. Gupi?
Sure. So focusing on, I mean, have a real concern around the impact the hostile environment is having on migrants. It's a term that has been used and led by the then Home Secretary Theresa May. And the reason I'm concerned about it is because the government have been challenged on this policy in places where it's been shown to be discriminatory. And yet they've said that it's fine for that to happen because of the need for it to exist because of immigration enforcement. So they are happy with evidence of racialization and racial discrimination as a result of their policies. And that has been challenged in the Supreme Court, and they've appealed that challenge. So we're working with a government that really doesn't care too much about racialized institutional racism and discrimination. So what does that mean in terms of what we need? And I think basically we need to work out ways in which the evidence that we gather needs to be strategic and enable the communities that are affected and the sort of broader movement to be able to build power and create change. And as I mentioned, there has been some concession in the government, but we could probably push forward a lot more. So speaking a little bit to the project that I worked on earlier, I think the reason it was so good is because it brought together those kind of multifaceted professionals, so academics and policymakers and campaigners. And in doing so, we were able to do certain things like just challenge the mindset behind existing data sets. So one of the things that we received were data sets on sex that was binary rather than gender identity, which is much more fluid. And how can we actually challenge data analysis to be able to express the multiple ways in which people identify in their gender, and also look at the way that wording around people of color or racialized people is often referred to as race, whereas race is a social construct. So why would we use that to reinforce the idea that race is a biological thing? It's not a biological thing, it's ethnicity or racialized identity. So there's just this useful and interesting challenge that can come with the collaboration of people from an academic background who may work with more institutionalized language and framing versus those that are more engaged in the kind of movements and the political movements in which we're trying to challenge that institutional framing, and making that collaboration more strategic to be able to then express the real experience. And the other side of that is also the way in which migrant communities are talked about in a very kind of passive way. So thinking more about how the system is actively working against them. So people within the immigration system rather than migrants themselves. And I thought that process was really useful in order to challenge the kind of myths and perceptions behind hard data. And I guess one of the things that we need to begin doing with that data, and this is something that I found with the UCL Lancet Migration Commission from now 2018, November 2018, when it released, was just how powerful it is to have data to be able to challenge sort of dominant ideas and provide alternative approaches to immigration practices that can be seen as more viable and sensible and more humane, which is sometimes used as a challenge because they're seen as unviable. And I think one thing that we need to kind of accept among all of us is that people will continue to move. People who have always moved and they will continue to move. The thing that's happening in the UK is that we have extremely hard borders. It is incredibly hard to actually get into our country. And what the government are doing are making it much harder for those who are in the country already, making lives much harder for them and basically forcing them underground so that they are unseen. And we could take a lot of leadership from Ireland who have moved towards committing regularization of undocumented people, as well as, one of the immediate things they did in the pandemic was to just drop all forms of charging and transfer of data between the Home Office and public services as a means to ensure that people felt they were included in the health system, both from a strategic public health approach, but also a humanistic approach to the way we engage in the pandemic. And I worry to the lengths at which this government will use sort of xenophobic rhetoric and approaches to policy making in order to justify almost anything, and how that can be long lasting past the pandemic. So we have a real challenge to collaborate a lot more effectively with each other to ensure that the policy we advocate for are evidence-based, but also come with a kind of radical frame of mind as well about what is actually needed.
Thank you so much, Yupi. And I think that there will be some, while the Lancet Commission busted some migrant myths, I'm sure in this COVID-19 climate, we'll have a new set of myths that the data will be needed to bust. So thank you for that. Davide, over to you for your top recommendations. Have we lost Davide?
No, okay. There was some problem with the microphone. Yes, all the things that colleagues have said are very sound. In short, I would say in the short term, save lives, provide care, and stop harmful practices. This is what we need, including the deportation I mentioned before. In the longer term, I think we need to value migration more in society. We need more solidarity in the way we approach problems in the context of health crisis. We need more cooperation, solidarity between countries and work together, instead of working sometimes one against the other. So the underlying understanding to guide the way forward to do this thing that eventually want to bring to, an integration of migrants in society is first of all, the understanding that exclusion is costly and inclusion pays dividend. The second thing that we have heard throughout the crisis said by many is that no one is safe until everybody is safe. So I think there is this understanding need to be translated in facts. The third point is that responding to the pandemic and protecting rights, including in border and migration management, is possible. The two things are not contradictory to themselves. The question is to identify those practices that are harmful. And in that sense, I think we need more training, particularly of administrators, public officials, that need to understand why their migration policy might have a negative effect on the control of the epidemic because of exclusion and the creation of new problems. Last, I would say, is migrants are part of the solution and not only the problem. We have said before that they are care providers, they are food chain suppliers, they maintain the system in which we've been able to stay at home during the lockdown. Without them, maybe we do not have food or the service they maintain the society. This has been understood in a way, but the translation into supporting migration policy of integration is still to come. Anyway, all of us, I think we have raised negative point, positive point. I think we need to work on those positive points and really, you know, over time, as we hope, come out better from this epidemic.
Are we there? And I think now moving quickly, we have 10 questions. So what I'm going to do is I'm going to try and group some of the questions together so that they can be answered by the panelists. The first question is to Julian from Lena Dominelli. And Lena asked Julian, how many COVID cases and deaths have occurred in migrant and refugee camps in Colombia? And I also see that on the chat that Julian has posted the policy brief from Colombia, Mexico. Julian, would you like to answer this question?
Yeah, thank you. Well, first, there is something that I have to clear up. Colombia's migrant flow is mixed, including refugees, indigenous, pendular migrants, and economic migrants. But there are not exactly something like refugee camps. Many migrants live in cities and are integrated to the society. If there are shelters for homeless, but certainly we have shelters for homeless people and workers, mainly alongside the border. Although it's expected that Venezuelans constitute an important part of the cases of the disease of the country, as it's represented in Colombia between 3 to 4 of the population. Currently, only migrants will intend to stay in Colombia. I mean, not including the migrants in transit or the pendular migrants. Unfortunately, the public information currently available on the incidence of COVID-19 among Venezuelan migrants is very limited. Well, but in 1 minute. However, almost in the start of the Venezuelan exodus to Colombia, the Colombian Minister of Health has elaborated as a porter of disease of public health interest in this population. According to this report, by the end of May, 136 cases of COVID-19 have been reported in foreign persons from abroad, of which the majority were Venezuelan, 84. But unfortunately, this bulletin does not include migrants living in Colombia who at this time, given the closure or the close of the border, represent a larger population than transit or pendular migrants. There is not also data on the case in transit and pendular migrants, especially since given the border closure, this is difficult to register. For all this, it's not possible to determine with certain the number of migrants affected or dead by COVID-19 in Colombia, but certainly we know that they are vulnerable and maybe we are going to have an important number of deaths among Venezuelan people. Finally, just one thing, we don't trust in Venezuelans data about COVID-19. If you see the data, it's impossible that the data are real. And as the pandemic increase, we are gonna see the real impact in this country, as some of this impact is gonna come to Colombia. Thank you.
Thank you so much, Julian, for that. And I think that is one of the big challenges, really looking at data and looking at how complete data is and how reliable it is. So that's a very important thing that you point out. So the next 3 questions are really for Raj. I'm just going to read them out and then Raj will answer them one by one. The first one is from Lena Dominelli. And she says, Raj, you mentioned foreign birth as the basis for determining status in the UK. Surely this overestimates the numbers that are not British, because many of them have acquired British nationality status and should be counted as British. They are settlers, not migrants. That's question number one. Question number two is from Joanna Walker. Given we are in the middle of the pandemic, the huge differences in quality of mortality data between countries and differences in recording methods and approaches, do you think country comparisons have any real meaning? Yes, they can be used to look at changes internally, but are the comparisons valid? And the third question is from Shobha Srivastava. And the question is, the numbers of healthcare workers who have died due to COVID-19, 73% were from Black, Asian, ethnic minority backgrounds. And among doctors, it was even higher. What has been done about this, please? So Raj, your time starts now. Raj, we cannot hear you.
Right, can you hear me now?
Yes.
Firstly, yes, of course. So we tend to analyze data here by self-described ethnic group. So we ask people what their ethnic group is, and we analyze the data using that. We also tend to have statistics about country of birth. Like, for example, I was born in India, brought up in Scotland, but I'm British. But it doesn't mean to say just because I'm British, my rate of risk of heart disease is not 3 times that of the white British population. It is, even although I'm British. So we tend to use self-described ethnic group as a primary variable for analysis. Country of birth is a secondary one. We don't have migration status analysis in this country. At least we don't have routine statistics by that. Second question was, just remind me, Bernadette, the second one. The third one I can remember, which is about doctors and nurses. Yes, a high proportion of ethnic minority populations in the UK work on the front line in the care of the elderly sector and also in the National Health Service. And they're at very high risk, firstly, because they're in those jobs. And secondly, even from their backgrounds, they tend to live in places where there's overcrowding. And thirdly, because of their susceptibility, because of comorbidities, especially type 2 diabetes. So what is being done about it? There's been a lot of recommendations, and people are working on it. Let's say they're working on it. There's going to be employer-led risk assessments, and they'll have to take that into account. So the middle question was, which one? Yes, international comparisons. The answer is international comparisons at a global level are impossible. Apart from anything else, the WHO does not get sent age-specific rates. It needs those age-specific rates so it can calculate directly standardized rates for across the world. That's the only method that actually works. So they don't have those data because the countries are not required to send them to them. But I think we can compare European countries, for example, but we do still have to age standardize. So I'm working with colleagues from Europe. We've got a letter in the International Journal of Epidemiology coming out, where we set out the method, and we've now got something like 9 or 10 countries. Paper is in my inbox for examination. We're going to submit it. So the answer is we can, but we have to use methods that work. For example, age standardization is critical, but we can also use excess deaths. If we can get weekly or monthly deaths for a country and we work out the excess compared with the last 5 years, that's a fairly reliable statistic. Death data tend to be reasonably reliable. Hospitalization and complications data are very unreliable, and incidence data can't be really compared. But if you had a good antibody test and there was a high quality one and you used it in different countries, then the results would be comparable. I've finished, Bernadette.
Okay, thank you very much, Raj. There are more questions coming up, but the next question is from Abhi, and I think it would be very good for Aurélie to respond to this. The question is, considering the healthcare surcharge is set to increase for non-health workers, it doesn't feel as if the government will continue to make healthcare more accessible to migrants. What can be done to persuade the government to adapt their approach? How can we utilize the unequal outcomes revealed by the pandemic as leverage towards positive change? Aurélie?
Sure, thank you for the question. Yeah, it's a very challenging question actually. I think with COVID-19 we have even more means of pressure with governments in terms of migration and health practices. So we definitely need to use this opportunity to expose the problems that we're facing in terms of access to healthcare for marginalized groups in our societies, especially undocumented migrants, refugees, asylum seekers, where in many countries don't have access to basic health services. So that's an opportunity we have, but obviously we also need to be very careful because it's not only about public health. Individual health is as important, and it has been neglected during this crisis. So many people don't access basic health services because of the restrictions, the lockdowns, because they are in quarantine, because they are in camps, and services have been limited. So we need to show with data that that this approach cannot work in the long term, and that cannot work as an outbreak response. So there is an opportunity that we need to use, but with a lot of attention, as well as to not only focus on public health, because that's not only that's not the only goal that we have. We need everybody's health to be respected and protected, regardless if they have COVID-19 or not. And we need to point as to contradictory practices, resort to measures that are counterproductive in terms of public health purposes. And we need much more effort in collecting this data and also informing the public and involving migrant communities as well in the way they want to organize outbreak responses, because that's also been lacking, and that's very important.
Thank you, Aurelie, for that. I think that this is something that we have to build as we sail, so to say, because there are no quick fixes, and I think some of it we'll just have to learn by experience. So thank you for those insights. The next two questions are for Guppy, and I'll just read them out. From Anonymous, saying, I have been volunteering in a mutual aid community organization for migrants and refugees, many of which are NRPF individuals. Whilst we originally received funding to be able to respond, it is becoming clear that we are starting to reach donor and volunteer fatigue. Yet it is clear that the numbers seeking assistance are only increasing as many continue to be unable to find employment opportunities. How should organizations and indeed the government respond to the longer-term challenges and recovery process of these groups? And the second question, Guppy, which if it's possible for you to answer, as we have talked about failings of UK government, especially to incorporate disability group, what would you say is the most positive step they have taken? Is there one? Guppy, over to you.
Okay, let's try and answer that one. I'll do that in order. So I think the emergence of the mutual aid networks where communities have come together to support each other has been really amazing. One of my fears is that it lets central government off the hook to attend to needs of vulnerable groups who are being left off, and isn't enabling us to see what's happening because of the reliance. I think the community effort is amazing. I think it's much needed because we do have a state that is neglecting communities, but I can't see how it can sustain itself in the long term without quite a huge amount of resource behind it. Quite fundamentally, what the government needs to do is to scrap NRPF. Like, it's been asked to scrap NRPF. It can very easily do so in the same way that it can quite easily scrap the charging system and most parts of the hostile environment. It's not difficult to, and we have seen the government do U-turns on several things during this pandemic, an example of which is funding free school meals for kids during the summer holidays, which was largely based on one action of a footballer called Marcus Rashford. And so if that is possible, then I think it's very easy for the government to create a system in which people can access things they need to. And the last question about something positive that they've done, I mean, I suppose the approach to the immigration health surcharge for the medical community has been one step forward, but there is a sense that they are making these very small concessions within parts of the immigration system, which is actually even more complex to administer and create an infrastructure for. So why won't they just wholesale scrap the immigration health surcharge altogether? And I think using things like strategic litigation in the way that Detention Action have done, in using evidence-based data and campaigns, and by doing much more mobilizing within our institutions collectively. One of the things I really appreciated during the investigation into the number of deaths within the BAME community was just how much there was a collaboration between medical institutions, medical unions, people of color, journalists, and think tanks and researchers working together to push Public Health England to actually move forward on doing that investigation. And we just need to see more and more of that, specifically in the immigration system and interrogating the immigration system and the impact it's having on migrant communities, more so than just the BAME community as a whole in the UK.
Thank you so much, Krupi, for that. And I'm sure that's not the last word on the topic. I think that this is something that will be an ongoing discussion for a while to come. The next two questions are the next question. In fact, there was one question in the chat and one question here from Roshan De Silva, and it was Nathalie Simino in the chat that had the same question to Raj. And it says that children do not get it too badly, but there have been numerous cases of very young people dying or suffering badly. Now, at the time that the US, UK, and other countries are restarting schools, will this lead to a new second wave and maybe prolong this pandemic further into the future with the possibility of children being super spreaders? Raj, over to you.
Well, firstly, it would be silly to say that it doesn't affect children at all. It does, but so does the common cold, so does influenza, so do road traffic accidents. Children are far less likely to be killed by COVID-19 than they are by road traffic accidents. We don't stop them going to school because we're worrying about road traffic accidents. So they're less likely to be killed by COVID-19 than influenza, although they are already immunized against influenza. We've published the statistics. I've sent the statistics to all attendees. Secondly, children are far less likely to spread it to anyone else. In Scotland, the new Scottish guidance is grandparents can give their grandchildren under 11 a cuddle. They've not to shield. When the children go back to school in August in Scotland, there's no shielding for children. They have to be shielded from their teachers, but that's to protect the teachers, not to protect the children. I've also sent round a preprint of a paper which is called a Zugzwang paper, Public Health Zugzwang, where I explain in great detail, it's a long paper, why there's no quick fix. In my view, we're dealing with a 5-year problem. Are we going to keep the schools closed for 5 years? Children are not super spreaders. There's evidence, plenty of evidence. Well, it's not, I wouldn't say it's absolutely sound evidence, but there is evidence that children are less likely to spread this disease than adults. And their immune systems are so good that they actually just deal with it. Immunity against viruses is largely from cells, the macrophages, the killer T cells, the lymphocytes, the white blood cells. Antibodies are only a backup system. And children's immune systems seem to be so good that they just wipe up the virus and get rid of it. And we've been worrying far too much about children, especially children under 11. Under 20, I mean, I'm on the record as saying if I was under 50, I would rather have the disease than be made unemployed, because the dangers of employment for people under 50 are probably greater than the danger of getting COVID-19. It's when you're over 75 that COVID-19 becomes quite serious, but the mortality is about 3%. It's not 100%. People have got all the statistics wrong, because if you're diagnosed with COVID-19 and you're over 80, your mortality is about 13%. But the vast majority of people are not diagnosed. Even over 80, they're not diagnosed. The mortality rate for people, the infection mortality rate, if 1,000 people got this disease, most of them won't even know they've got it. And for most of the rest, it's a very mild disease. Some people are getting a very severe variant for reasons we don't fully understand. But anyway, I don't have all the time to go into this, but this paper that's just coming out, it's I've sent the link. It's an open access paper, so people can look at the arguments. I'm an epidemiologist, so I don't really like to make any conclusions without having the numbers, the statistics. I only look at the statistics. And if you look at the statistics for cause of death from COVID-19 compared with other causes of death, and we've now done it for every age group. So we haven't published it for every age group, but I've got the data for hundreds of millions of people from many countries. Our children's data is based on 135 million children from 9 countries. These are not trivial numbers. 40 plus deaths, and we've updated it, is now up to 60 deaths in this huge population. The number of deaths from influenza is twice that. So I'm not trying to kid anyone. I've got grandchildren, I've got 4 children. Of course, I worry about them a little bit, but I want my grandchildren to get to school as soon as possible. Now, I worry about the teachers. I worry about their parents and grandparents and great-grandparents, but I don't worry about the children. And people who say I'm scared about my children, that's just an excuse. Teachers are scared for themselves, and they should admit it. They shouldn't be scared about the children. They have to be scared for themselves. So yeah, let's look at the numbers, statistics. Let's not draw too many conclusions without doing the statistics. We hope to have our data on all age groups published, where we've actually shown that that compared with other causes, it's only when you get to older age groups, over 70, 60, that this becomes a serious major cause of death. I don't want to trivialize it either. It can cause death at any age. But my son is in an advanced stage of pediatrics. He's been leading he's been one of the leaders of the campaign to get children back to school normalized. The UK pediatricians have, as a body, 1,500 of them have said it's time to get children normalized and back to school because they're being very badly damaged by lockdowns.
Thank you, Raj. I think I couldn't agree with you more on that issue regarding children. I think Natalie has just put something on the chat saying she was also talking about young people. But I think your answer, where you have said that you have done it by all age groups, is an important one, looking at the different rates. We're running out of time, and we have 3 more questions. So I'm going to ask Davide to give him his best shot to the remaining questions. The one question is on temporary citizenship to all countries by anonymous, to all migrants currently located in a country where they're applying for migrant status and asylum. As COVID-19 will be with us for a long time, what any other long-term solution should be done for migrants? That's one question. The second one is from our good colleague, Alan Krasnick. And Alan says, thanks for excellent presentations. Mobilizing ethnic minority and migrant health professionals, as well as community representatives from these groups, seems to be a strong tool for prevention and care of COVID-19. Do you have any good examples illustrating this? And the last question is from Anne Jackman. Of your knowledge, is there a reliable COVID-19 rapid test, as this would simplify testing of migrants without needing laboratories? So Davide, if you have a go at this, and then if anybody else would like to add, they can do so. Davide?
Okay, thank you. Well, of course, there is no quick solution to problems that are deep in society. We have to recall that the migration policy, politics, and sensitivity have been determined by long-term other crises, starting probably the 2007-8 financial crisis, going to the Arab Springs and the European migration crisis of 2011, 2015, maybe the Ebola perceptions, 14, 15, and more of all the geopolitics of sovereignty, populism, and fights everywhere. So it is very difficult to have alternative solution in terms of citizenship integration that can be taken globally. So every reality is different from another. We see some good practices. I mentioned before this report of the UN Secretary General, the COVID and people on the move, that reports some good practices put in place by countries like Portugal, even Ireland, in Italy, with the change of government. There have been some discussion about the change of the legislation brought by the previous right-wing government we had until last year. So the changes in these terms, in terms of migration policy, can come. What we have always said, providing more evidence, advocacy, good practices, training, engaging communities and parliamentaries, legislators, all these things is what is on our responsibility, and I think we are trying what we can in that sense. Some progress exists, but we cannot expect that this thing is going to be sorted out quickly. As I said before, maybe the crisis has opened, however, that understanding that exclusion is a risk, and based on the good practices that some countries are taken, maybe work on that and convincing others. Of course, regional approaches, dialogues are also important in that sense. When it comes to mobilizing the health community, whether pertaining to ethnic groups or not, is definitely a positive thing, because they have been the responders. They've been called heroes in many countries. They have died. So I think they have now the challenge to get in that debate. And unfortunately, as we know, the clinicians are taken by their clinical work, and sometimes they don't have the time, the luxury to engage. So reason why maybe journals like the Lancet, that are read mainly by that kind of public, and not only, maybe they can play a role. I'm happy to see, for example, the International Society of Travel Medicine that has taken a more continuous engagement into the issue of migration. And that society is a society of clinicians from all over the world. So I think we have the possibility to mobilize the health practitioners to force and advise more on policy and political changes. This is the hope. In terms of testing, well, it's a complex thing. I think that the rapid tests are not enough to tell whether a person is really currently affected or possibly a source for infection for others. So I think that a rapid test, though exists, but I don't think it's time for consider them a screening mechanism for migrants. I don't know, it could risk, without the proper management, to create more misperception than benefit. So I think we should wait and see better, and only advocate for migrants to be fully part of the same schemes of control that is put in place for the general population.
And with that, we have actually run out of time. So I'm going to wrap this up in exactly 30 seconds. There were two important comments from anonymous attendee talking about the issues that we haven't talked in general, but are very important. And that is the support to migrants, including isolation, mental health, concerns of shared housing, longer stays in initial accommodation, quality of food given, lack of support, emotional well-being, and it's a long list of issues that have to be tackled. And as one of the panelists mentioned earlier, we cannot wait it was Julian who said, we cannot wait for the pandemic to be over to deal with issues of migration and migrants, and in particular, looking at integration. Also, if we need data, and as Julian again said, but there's no funding for it. And another question was, there's a lack of international funding. I'm aware of various funding opportunities both from the UK and the EU, but international funding, in particular for low and middle income countries, is difficult. But if you do send us emails, we can try to find some sources and send them to you, because now funding is becoming available, though it is quite difficult to attain that. So I think it would be impossible to summarize everything except to say that this particular situation that we are in now finds many, many layers. There's the migrant crisis, there's the health crisis, there's the COVID crisis, there's socioeconomic conditions. And I think that we have to work with all of this together. We cannot wait. There are access issues. There are issues related to temporary citizenship being granted. There are issues related to structural racism that have to be dealt with, issues related to inclusion and integration, issues related to dealing with hostile environments, of busting the myths, both old ones and the new ones that will come to arise. And importantly, that all of this, we have to work together. The migrant and ethnic minority health community has been working consistently together. And this COVID-19 opportunity is really to build again solidarity and cooperation across borders, and not be excluding, but trying to be including. And ultimately, as the UHC goal is not to leave anyone behind in this crisis, in particular, not migrants. And with that note, a very big thank you to the panelists for their time and for the excellent presentations. And thank you also for a very active audience that had excellent questions. I'm sorry if we couldn't go into depth in all of that. And thank you for the organizers. And good evening, or rather good night from Kathmandu from me. Thank you.
Okay, thank you, Professor Kumar, for moderating the panel discussion. And really, we're thankful to all the panelists. They are joining us from different continents, from Latin America, Asia, and of course in Europe. Thank you, all of you, and also thanks to Miriam, as she is absent today. And now we will take 10 minutes short break, and then we'll come back again here for the PhD showcase. So 10 minutes in this platform, please come back here.